So, thank you for talking with us today. Would you please introduce yourself?
Yeah, I'm Dolf Pfefferbaum. Real name is Adolf. No middle initial, no middle name. And I am currently, I guess I'm a distinguished scientist at SRI International in Menlo Park, and I'm professor emeritus from Stanford. I'm a psychiatrist by training and an alcohol researcher by profession.
Thank you. So, how did you move along in your path in alcohol research? You can go back to adolescence or so if you want.
Yeah.
What were influences in your life that led you to science, to this? And were there people that along the way that had special impact?
Sure. Like I said, I got out my CV in preparation for this. That's kind of where you keep your history. The first paper I was on was in 1967. It shows you how old I am. I may be the oldest person at the conference here.
Really?
I'm pretty close to it, probably.
We've never seen it now.
Well, thank you. So like I say, I'm a psychiatrist by training. And so I wasn't particularly interested in alcohol early on in my career. That first paper was when I spent a summer at NIH in a laboratory between my second and third year medical school time. So from medical school, I was an intern in St. Barnes, St. Louis. And then this was during the Vietnam War. So I spent 2 years at the NIH, 69 to 71, called it the Yellow Beret then, because if you didn't go to NIH, you got drafted. So I was in the Public Health Corps, and I worked in a lab with Monty Buxbaum, who's still, I think, still working. And actually, my first mentor would be Enoch Callaway, because when I was a medical student, I worked in Callaway's lab. In fact, I worked there the summer before I started medical school. Enoch Notch Callaway had an electrophysiology lab. We did human book potential work long before computers existed for it. We used something called a computer of average transients. And that got me to NIH in Monty Buxbaum's lab, where I spent 2 years. And I was looking at this. So my first author paper was in 1971. So that's how long ago it was. So from NIH, then I became a psychiatry resident at Stanford. So I was a resident there for 3 years. And it's interesting looking over my CV. In those early years, I don't have many publications. There were a few kind of drifted out from my time at NIH. And it took a while till I got started again. So I started on the faculty in 71 as an assistant professor. And I went into Bert Koppel's lab. Bert Koppel and Tom Roth and Jerry Tinklenberger, people I remember from those years. Jack Barkus, Phil Berger. These are all old Stanford memories. And I was mainly interested in schizophrenia because that's what we treated there. And so for at least 10 years, I did electrophysiology research in schizophrenia. But right upstairs from our lab was an inpatient alcohol rehab ward where we saw real alcoholics, real alcohol use disorder. They were men, they were only men, but they didn't have polydrug use. They were there for 30 to 90 days, so we could see them very early on and we could see them when they are detoxified. And I got into it because we wanted to look at them in contrast to people with schizophrenia, because we were finding signals in schizophrenia, where Tom Roth was the one that first noted this, that they had a reduced P300. If you were at Bernice's lecture today, she was talking a lot about the P300, and so that's this cognitive evoked potential. So I was in the electrophysiology business, and when we got a group of the patients from the alcohol ward and ran them. Lo and behold, they had P300 deficits also. They also had latency deficits. So that was a different kind of marker, more of a cognitive delay. And so I was looking at the numbers here. So in 70, don't remember when I did the first one, but in like 78, 78, I finished the study. 79 was published. One of them's in Acer, but I think this is in the EEG journal. I got invited to what must have been the precursor of ISBRA in Zurich, Switzerland. And I met a man named Henri Begleiter. And he was there with Bernice. I remember how nervous I was. I still remember walking around the town and rehearsing my talk. And so I met Henry. You're doing P300s? What are you finding? And that was the beginning of a relationship with Henry that lasted until his death. So he was always a really good friend, mentor, encouraged me to expand beyond electrophysiology. So I had these two tracks going now. Was successful in finding things in alcohol use disorders, and we were also successful in schizophrenia. And then, the early 80s, there was a call for centers or program projects grants from NIAAA. It must have been NIAAA, then probably when it was in Adam Hoff. And because I'd had a publication or two on comparing alcoholics and schizophrenics, they made me the head of the thing. Dominic Perper was the dean at that time. I remember getting him to sign in. The number at that time seemed really large. It was probably like $500,000. It was nothing in today's, but he was impressed with that. I can remember getting him to sign it. I wrote with Terry Jernigan. Terry probably did the majority of the work. One of the portions of it, one of the segments. We didn't get to center, but Henry called me up and he said, you should submit that as an R01, which I did, and is now in its 38th year.
Wow, so impressive.
Yeah. So and that, along the way we had schizophrenia grants too. For 10 years I was the head of a schizophrenia mental health center. So I had these kind of parallel careers going on, and that went for a while. It was just going with both of them. So I went from electrophysiology. This is how old I am. So I remember when the first CT scans came. And so one of the very first things I did with CT was with Terry. Gosh, in those days it was so primitive. We wrote our first paper on age-related changes, just normal people. We had these little films, and we got a big table, and we put them down on pieces of white paper, and so you could kind of see enough. And Terry and I and the chief of radiology at the VA went around putting them in order in terms of the ventricular size. And so we did that until we agreed on what that was. And that was our first paper in the Computer of Average Transients, the CAT journal. That was a long time ago. And so we did CT research. That was our main alcohol research. Alcohol and schizophrenia was CT. So we migrated to CT. You want to hear this whole story?
Yeah.
Okay.
Yeah.
We migrated to CT, getting bigger computers. We got one of those old Vaxes, and we were able to get the CT. Get the CT images. And that's when Kelvin Lim came to the lab. Kelvin's here now. He's you want to hear about people in the past that were there. So he would have been my first quote student, though we were really peers because he taught me. And he's now professor of radiology and psychiatry here at University of No, we're not in Michigan, Minnesota. Yeah. In fact, I had dinner with him last night.
Good.
And so we did the CT work. And so now we're almost 10 years down the line, and the MR comes. And we decided, the beauty of MR, not only its resolution and all those things, but there was no radiation. And so we could do people as much as we wanted. And I remember in the old days, you had to make a cognitive shift in interpreting the images. When you did CT, you had to do it at an angle so that you didn't irradiate the eyes. And so everything had a slightly different look as you went. And there were parts of the brain you didn't get, some of the far frontal stuff. And so when we went to MR, you could actually do perfectly orthogonal images. It took a while just to get used to that. Kelvin and I were reminiscing last night. So we went around the community and got tapes from various MR facilities. And they said, you won't be able to use these, but we'll let you have them. And we decoded the codes of the image formats. We're able to collect a lot of data. I think my most cited paper is like a 1990 paper in the Archives of Neurology, where we got from age 5 to age 80 of MR scans around the community, and read them from all these tapes.
Excuse me.
Well, I'll take,
I'll edit out.
that got us into the MR business, and we weren't the first to do imaging of alcoholics. There was a paper in Science, I think Wilkins. I don't remember the first author now, but they did show a really significant difference between chronic alcoholics and controls, or maybe they haven't been detox. I'm not. It's been so long, I don't remember. I used to have that in my armamentarium. So along about 1988, here's the thing. There's AD and BC. Okay, when you think about the century, 2000, well, in a real scholarly way of talking about it, it's not AD, it's CE, Common Era, and it's not B. It's not after Anno Domino for after Christ, and it's not BC before Christ. It's BCE. Mm-hmm. Well, BCE is the time I've been talking about. That's before the coming of Edie.
Edie Sullivan.
Yes. So in 1988, Edie Sullivan came to the lab, and Terry Jernigan had been, still is, a neuropsychologist, but she had actually introduced me to the brain imaging because she had been working with the head of radiology. But when Edie came, there was a real new emphasis on neuropsychology. And so she kind of started pushing that. And she came, started working with us. Our first paper together was in 1990. Okay, so that's 34 years ago. Yeah. She came in '88. The first paper was actually she's on one of the ERP papers, but then we really did start taking off with MRI. People that were in the lab at the time was Kelvin, Bob Zapersky, who's now professor at McMaster in Canada. Who else? So I mentioned some of those other early people. The next group of people come from when we moved to SRI. So we had kind of continued with schizophrenia until about 1996 is when we moved to SRI. So we moved the lab to SRI for a variety of political reasons, but it did turn out that, as Edie said, we were thrown into the briar patch because when we got to SRI, we had been doing all of our imaging at the Lucas Center at Stanford. So we would take patients over there. The CT work was done at the VA in the radiology department. But when we got an MRI, we had to take the patients over to the Lucas Center at Stanford, and that worked okay. When we went to SRI, GE was looking for a site to put a scanner that was neither at Stanford or UCSF because they were trying to work with both institutions, and they wanted a GE site where just the GE people were. So they wanted a neutral site. So we were the neutral site. So along with them comes a 1.5 and a long bore 3T. So we really, all of a sudden, we had at SRI two magnets, of which part of the deal, it was a rent for magnet time. So we got half a scanner to do anything we wanted in terms of research imaging. So that's where, I mean, things really heated up. I mean, we basically were unlimited in what we could do. We were limited by the patients we could get. We kept we had strong affiliations with, at that point, our affiliations were more with radiology than they were with psychiatry now that we'd moved over there. So I worked with Dan Spielman. You know Dan. In fact, Dan, Gary Glover, Al Makovsky, and I talk about MR lineage. Have a paper in ACER on spectroscopic imaging of alcohol in the human brain. And the bottom line is it distributes with water. It's 99% in the CSF and 90% in gray matter and 80% in white matter. We wrote a grant on that, didn't get it. And I thought, well, what can I say? Did you review it?
No. I did not.
In those days, you probably were still in knee pants in those days.
What year was that?
1990, I think, is when we did the ACER publication.
I had another year to go for my PhD.
Yeah. Okay. So
you can't blame me for that.
Yeah, I can't blame you for that. And then along came Dan's student, Elfar Adelsteinson, who's now, and he worked with us and was in our lab and was with us part of the time at SRI. And he's full professor of electrical engineering at MIT. I mean, there've been a lot of great people. Danny Mathalon is a professor of psychiatry at UCSF. I mentioned Bob Zapersky. Who else? Let me look here.
Kelvin Lim.
Kelvin. I like to remember some of these people. Through the years, we've also had a whole French contingent come. We've had French postdocs come through the lab. In fact, we got a grant from NIAAA for an exchange. So we had Annalise Patel and Sandra Schoenrod. They're both Annalise is a professor at Caen. Sandra's a professor at Bordeaux. Just recently, we've had Valentin Chernikov, who came to us for 6 months and finished 3 papers she got published. She brought all the data with her, but I have to give Edie credit for that. There's Danny Mathalon.
How did your French connection come about?
I don't know, but I loved it. I mean, it was good. I think TK is probably the one. I haven't gotten up to TK in our history yet. I think TK did that. I don't know, but for years we've had a French connection. And, she may not tell you, but Edie got an honorary doctorate from Sorbonne a few years ago, and we go there a lot. We had a connection with Caen with that grant. I think we kept that for either 10 or 15 years. And so we would go back and forth. I never spent any time in France, except for conferences and visiting. But we had these 3 different postdocs that came, and that was great. We had a postdoc, a psychiatrist, Eugene Jung from South Korea. He's now a professor, and I think he's chair of the department there at Yonsei. And then I'm trying to think. So along the line, like I say, we could do anything we wanted with the scanner. We got a set of inserts from Brian Roth, actually, is where they came from in Canada. And These are gradient inserts that go into the human scanner. And so you got the field up, not the field, yeah, we're still at 3T, but we could scan small animals. So we did our first animal imaging in a human scanner. And that's at about the time, well, I actually met TK much earlier than that, but that's about the time that they were going to do the INYA, the Integrated Neuroscience Initiative in alcohol. And I got invited to a discussion of the group. I remember we flew into Denver. TK's plane was late, and they didn't really want human imaging, but they thought maybe you could do some animal imaging. And so we thought, what the heck, we'll give it a try. And so we did our first animal imaging on this human scanner with these inserts. It was a big deal. It had to be water cooled and move hoses around. It didn't have any good gantries or anything. It was just pushing them in by hand. And we did a lot of work with that. We did a lot of good work with that. That was long before we got 7T. That's way longer here. But from that work I do have 2 publications with TK. So I'm it's one of my fond memories. I never published with Henry. I published with TK. Are we long, short? Are we going?
We're good.
Okay. Published with TK. No, but how did I meet TK? I was at a RSA, and I got invited to one of the, they have the extra receptions for people. Well, I'm there and having a glass of wine. TK didn't drink because of his stomach. And I said something about, oh yeah, I don't have any trouble because my liver enzymes are induced. And he looked at me and he says, your tolerance has nothing to do with the induction of your liver enzymes. That set me to realizing that I didn't know much about alcohol physiology. Of course, Mr. Alcohol dehydrogenase had set me straight. And the thing I always tell people, tolerance, 10% of tolerance can be ascribed to alcohol dehydrogenase, and the rest is God knows what. That's something I'm still interested in. But so that's how we got into the animal imaging and how we got into ENYA. And we were in that group for 20 years. George Koop was the head of it. So that was a great time. And we did that. We finally graduated. Ian Coleraine became administratively over me. He'd been in my lab and then he became a big shot. Such a big shot that he managed to get the Institute to put out for 7T animal scanner. So that really changed our, I'm going to blow my nose.
Yeah, I can edit that.
That changed our animal imaging work, some of which you're looking at right now. And along that time, so Elfar was in the lab. He worked with us. Dirk Mayer. Dirk's now a professor at the University of Maryland. These are more spectroscopy guys. And I dabbled in spectroscopy. So Edie and I went to SRI, and then, gosh, it wasn't long after we were there that Natalie Czar came. And so Natalie picked up a lot of the animal imaging, a lot of the animal spectroscopy. In fact, she's right now pulling together something like 800 rat structural images that we've had for the last N years and doing an age regression change. And so this is a tour de force that she's pulled all of that together.
Yeah.
So Natalie came, and then Killian came. And so the other person, that's still currently with us is Killian. They both came as investigators at SRI, but they are now also on the faculty at Stanford. So they they came to SRI, and through that, they got faculty positions there. And Killian's just been promoted to full professor, and Natalie's assistant professor, and I'm sure going to be promoted very soon. I hope so. Um, and so that's kept our Stanford. We basically, and Edie has always been a Stanford professor, even though the lab's been at SRI. So we've always had a Stanford SRI lab, and it's been a joint venture all the time. There are other people in the lab. Clive Hopper came and spent a sabbatical with us. That was fun. He spent about 6 months there. We did some neat things with him. We did some postmortem brain imaging. We got a postmortem specimen, I think, from him. And we got a cerebellum. We got a cerebellum from him. We did some work with that. We did some postmortem work on a woman in his lab. Did myelin staining of the corpus callosum of some rats that we had scanned. So we've been all over the place. Let me put it that way. Maybe you know, it's not entirely goal directed. It kind of bounces around.
As I listened to you, I was thinking that the techniques move around.
Yeah.
Say you're choosing techniques to answer the questions.
Yeah. And the technique. I mean, we've been like I say, we saw the first CAT scan, we saw the first MRI, and we've seen the development of the techniques, and we followed them. We try to be ahead of them a little bit, and sometimes we have been. I mean, we were very early in the schizophrenia imaging business, and we're very early in the alcohol. And there are all of them. I mean, we were into fMRI, and diffusion tensor imaging, and you name it, QSM, you name it, we've done it. Perfusion, applying all of these to alcohol use disorders. And then, so there was the animal work, which we tried to parallel to the human work. And there are some things from the animal work that, sometimes the animal people aren't happy with me, sometimes the human people aren't. Try as we might to give rodents, primarily rats, alcohol. You can gavage them. You really make them very drunk. You can put them in a vapor chamber for months. They always recover, except if you do thiamine deficiency. And Natalie and I did those thiamine deficiency things. And if you have thiamine deficiency, you can make a lasting lesion. Even it recovers a little bit in the rats. The brain changes, are graded from chronic alcohol use disorder, non-amnestic, the Korsakoffs. That's a lot of Edie's work. If you're a non-amnestic alcohol use disorder person in your 30s to 60s, if you stop drinking, there's evidence of some brain healing. Like some of our diffusion tensor imaging work shows that if you quit drinking, you get some recovery of that. And we can see certainly on individual cases, I can show you pairs of images where people keep drinking and their ventricles get larger. I can show you people that have pontine myelinolysis and the woman quit drinking and it recovers. So on an individual basis, we can see it. And we see it a bit, but we also see there's kind of a scar that stays with you. And you also get this, accelerated aging phenomenon. So the animal work doesn't perfectly parallel to human work. In fact, that's one of the interesting aspects of it. The other thing, of course, is the human brain shrinks as we get older. And the rat brain keeps going, at least as old as we've been able to keep them, certainly over 2 years. The thing is still expanding. So there may be more plasticity in these rodent models than there is in human. After all, it kind of goes downhill. So sticking with age, well, also 15 years ago, NIAAA put out a request for adolescent studies. So, we had always been concentrating on alcohol use disorders over the adult lifespan. Now here was an opportunity to get into adolescents, and that's the InCanda study. And there we were collecting from 12 to 21-year-olds before they started drinking. So the idea was to get people before so that we could really have an experiment. And it's now in its about its 12th year. Early on, we were able to show that if you started drinking as an adolescent, there was some signal in your gray matter especially, that it kind of, there's a normal decline in gray matter after, well, after about age 6, everything goes down, but there's this kind of pruning in adolescence. And if you look at, say, DTI at about 8, the fractional anisotropy increases until about age 18, and it starts going down. Qingyu Zhao, who just left us and went to Cornell, where he's a professor, assistant professor, another one that worked with us, has shown that kids that start drinking have a much more rapid decline in their fractional anisotropy. So we can see some signals in the adolescents as well when they start drinking. That's an ongoing program. And, there was a big symposium on it here yesterday, and that's very exciting because we've got these people now. Some of them are in their 30s, and so they're starting to mature into the age that we'll see. Can we predict who it was, and also through these early experiences they have, the ones who started drinking at adolescence and quit. Maybe they're okay. Maybe they kept drinking. So this is really actually an important study. It's a precursor to ABCD, and we did it better than them because we have this age sequential cohort. So because we collected people in 3 cohorts, 12 to 15, 15 to 18, 18 to 21, you can cross-sectionally see what should happen. And you can then see what happens to people as they progress. So for instance, if you want to examine somebody's cognitive behavior, if you test them at age 12 and then test them a year later, they do better. But they do better because it's a practice effect as well as a maturation effect. So we can kind of dissect out the difference, and maybe Edie will talk to you about the difference between growth and practice. And so that becomes an important thing. So that's ongoing. So we're still studying advanced age, we're studying adolescence, and then our latest endeavors have been from one other NIAAA interest, and that is in the interaction of alcohol use disorder and HIV infection. And so we're maybe in our 20th year of working on that. And there we have what we call our 4-group model. You have controls, you have alcohol use disorder, you have HIV infection, and you have people that are comorbid for both of them. And so we've done a lot of just structural work with that, but recently we started looking in these white matter hyperintensities. I presented some stuff at a satellite here on Saturday, looking at how it hits the thalamus. And so we're seeing a double hit, especially as you get older. So over about age 50, even if you're treated for your HIV, it's like the polio model, you've got a scar. And that scar stays with you. And if you drink, if you have an alcohol use disorder, you accelerate the deterioration structurally, white matter hyperintensities, and the integrity of your thalamus. So that's another thing that's ongoing with us. So, and then I guess the only other end of this, so we've got adolescents, we've got adults, we've got aging. Edie's doing work in mild cognitive impairment way at the end. And then right now I'm working on a project with Ed Riley on data we got on FAS from the University of Washington study. And Ed got the scans, the baseline scans from the 1990s, and we did a paper with him. Edie is the first author on the cerebellum. And then we got follow-ups 20 years later. And we just published that last year in JAMA. They don't progress. Okay, so over a 20-year period, the lesions are stable. They don't get worse, which is interesting. And we're in the process of getting some cognitive data there. So we've been from the bottom, from prenatal all the way up, and we've done some of that in the animal models too. And then of course there's our diversion into spectroscopy and glutamate and the work that I'm doing with Professor Mason, who's helping us see what we can do with spectroscopy and glutamate metabolism. So that's something that I'm doing with Graeme. And so we're still full steam ahead in spite of my advanced years, working on all these things are still going full force. But I have to say that Natalie, of course, but I counted them up with Edie. No, she counted them up. We have 341 publications together. Is that amazing?
Just your publications together.
Yeah.
So,
right.
Wow.
341 publications.
Wow.
So that's been a partnership for all those years. That's been, she brought neuropsychology and behavior, and I brought the brain imaging. And I always say, it doesn't matter what the brain looks like if the behavior doesn't change. It's, that's what really counts, including whether or not you drink.
Mm-hmm.
Yeah. So that's the history of my research in alcohol.
It's a journey, a long path ahead, and you're still at it.
Yeah, we're still at it. Well, Edie isn't going to quit, so I'm not going to quit.
Yeah.
So we're at 341. We'll see where we can go. We got to make 350 at least.
Yeah.
Yeah.
It looks to me like you see the opportunities that the technology and including the computation bring you.
Yeah. We were, and I will say, technology driven in part. I like to think that we even made some fundamental contributions to MR technology along the way. Some of our work, Dan Spielman and Al McCoskey and Gary Glover.
Oh, yes.
So I like to feel that we've done some stuff there. And I think that the driving one now, and maybe it just reflects my age, is this thing of what happens in the later years. And this interaction of aging and alcohol use disorder that I think is really important here. We're an aging population. Older people actually, I think, are starting to drink more, certainly older women. And it's important to know if indeed, if some of these changes, both behaviorally and in your brain, can at least be ameliorated, if not reversed. And I like to say, when I get told about exercising, I may not get stronger, but I won't get any weaker if I exercise. I think that's I think that's the key of what you do at my age.
Yeah.
Yeah.
Well, there I hear also some reason for optimism for patients, and you say you get recovery. It can vary in how much, but there's a plasticity can bring you recovery and help with aging.
Yes. Yeah.
And I ask, what would you talk about any challenges you faced along your path?
Challenges. Getting funded.
Yep.
You get that answer a lot. Well, okay. So personal challenges have to deal with university politics. That you and I have discussed that kind of stuff. That always happens, and of course, a big juncture in my life was moving from Stanford. Actually, moving from the Palo Alto VA. I don't know if I gave you the proper chronology there. So in 74, I became a faculty member and a VA employee. And so I had my lab at the VA for a long time. For a year, I was actually acting chairman of the department at Stanford. So that was a big rupture, big change. And so that was a challenge, is to move and, quote, start over again. And one of the saving graces is NIAAA was very supportive when I moved there, took my grants, and actually it was shortly thereafter that I got a merit award. So that gave me some real stability. And so that was a challenge. Yeah, the political part of it was a challenge. I have to say, but as Edie said, we got thrown into the briar patch when we moved to SRI, and it's true because we had this wonderful opportunity to collaborate with GE, and that's been great.
It sounds like you might not have 341 publications had you not moved.
That's probably true, yeah, because we were actually quite limited, and there was a freedom of moving from the VA. I mean, there were some advantages and disadvantages going from hard to soft money. So when we were at the VA, I was a full-time VA. In fact, I was chief of psychiatry. So I didn't even. I had administrative duties. I had clinical duties. But I had lots of sway, lots of authority. But at that time, I had so much administrative work that I really did not. I was not in the lab as much as I would have liked to have been. And so when we moved to SRI, that's all I did was research. In fact, I had to support myself with research. And so while it was a challenge, it was also a great opportunity. And that I became a full-time researcher. So I like to tell people I used to be a psychiatrist. I was until 1996. And then this is a big change. So I became a full-time investigator in 96. And that marked a big change.
And it sounds like it was good for the field of alcohol research.
Well, I hope so.
Some time ago, you had told me you did some work with the justice system in California.
Oh, yes.
Has that affected anything about your research or your perspectives on alcohol?
I don't know if it's so much on alcohol. It affected my perspective on life. It's very interesting. I was a psychiatric consultant to what's known as the California Youth Authority, which is almost totally disbanded now. It's a shame. I think I did it for 30 years. It was the one kind of moonlighting job you could do then when you were on the faculty. And so I would go to Stockton, California, and a place called Carl Holton School for Boys. That was a euphemism. It was a prison. but they gave it names like that. I mean, one of the, quote, schools had double tiers and guard towers. The one I was at was a little bit more like not like a summer camp, that's for sure. It had barracks and communal showers and had open beds and then some individual cells. And so I saw a lot of adolescents there. They were all age, I think maybe 14 was the youngest, on up to in their early 20s. And I got a perspective on adolescent development, not anything like mine or what my son did, but what most of these kids, they were either inner city or they were rural, a lot of Hispanics. The racial breakdown was about a third black, a third white, and a third Hispanic. And so the white kids that got there were far less competent because, they at that time they were 60-70% of the population in California, and blacks were only 10% and Hispanics maybe 30%. So the blacks and Hispanics were overrepresented and the whites underrepresented. My nose again. Obviously, cultural justice system disparities. And I saw kids there in those days. Yeah, they drank. They drank and used marijuana in those early years, in the late 70s, early 80s. Mainly they drank. They were inventive. They made what's called pruno. You know what pruno is? Oh, they okay. Well, pruno is you save your fruit from lunch and dinner, and right, they called pruno, but mainly they got oranges, and then you sequester it away, and if you can treat it right, it'll ferment, and you have alcohol. And of course, you have to hide this stuff, and so occasionally we'd show up with that, it would be there, and so it was a look at a different aspect of the society. As the years went by, I tried to get histories of maternal alcohol exposure because we did see some people that I would call funny looking kids. And there were kids that I saw there that I thought probably did have at least fetal alcohol exposure. I didn't ever see any really FAS kids, because if they were uh, cognitively disadvantaged that much, they wouldn't be in this because this is an open setting. It could be pretty violent. They would be at great disadvantage. But I did see some kids that I thought probably did have some fetal exposure to alcohol. That was long before I actually did any research. I mean, my research in FAS, FAE is just in this last few years within. But I was acute to that at the time, you know. And of course, when I was at the VA and we saw military people, their alcohol was, that was encouraged by the military in those days. As a matter of fact, when I was at NIH, 69 or 71, we used to go over, I think it's now, the Bethesda Naval is now Walter Reed, isn't it? I think they've combined them. It was 50-cent martinis on Friday afternoon and cigarettes, so they smoking and drinking back then. Yeah, so I don't think then it didn't. Those experiences have been interesting in looking at the kinds of people that we see now in our Canada study. And I recognize when we tried in Canada to recruit for high risk kids, I recognize some of the kids that I saw that were in the California Youth Authority. Yeah, so it was an interesting time.
Yeah.
Yeah.
I'm really looking forward to your perspective on this because of all the developments you've seen. What would you like to see for the future of alcohol, and what do you expect to see for the future of alcohol research, and what do you expect to see?
Oh, that's interesting. I see people with different motivations in the field. There are the pharmacologists that want to find a drug to stop you from drinking, and that's a noble effort. There are the kind of the social people who try to understand what the personality and experiences are that lead people to drink too much. There are people like me who are interested in the sequelae of drinking too much, or drinking modest amounts. I think there's still some debate about what moderate drinking does. I call it modest drinking. um, Henry Begleiter once said to me when we were on these review sessions, Henry had been the chair of ALCB1 back in Adamha when there was ALCB1 was the human and animal, and ALCB2 was the liver guys. And Henry said, I don't care what they do with their rats. It's people that matter. We've tried to bridge that gap. Will be a cure for alcohol use disorder? I don't think that's the right way to think of it. I think the way to think of it is, can we as a society, find a way to manage alcohol use. Uh, sometimes what I think we do is we want to scare people with pictures of their brain rotting away. I mean, whatever you can do to get people to do that. I'm wearing something called a Whoop, which is basically something that records my pulse and skin temperature. My son said I should have it, so I got it. And he said to me one day, said, "Oh, you look on this thing, and it says, 'Have you had a drink last night?' And you see what it does to your heart rate variability and your recovery." And he says he's cut down on his drinking. And so there are all kinds of ways I think that the society, individuals, the society as a whole, can manage the use of alcohol. Um, that's how we got into harm reduction rather than abstinence. And I think that that's somewhere got to be part of the goal of the alcohol field. Is how we do that. Because after all, even in spite of wearing the Whoop, I still enjoy a glass of wine with dinner. And so I think we need to emphasize that. I mean, we definitely need to find ways of dealing with real alcohol use disorder and all the problems it causes. And if we can discover, is there a personality or a physiological predisposition uh, to become alcohol dependent, then we should know that. We should understand that. Are there brain signals? Perhaps. Actually, Bernice's presentation on electrophysiology looked like it had some positive ideas and linked to genetics. So if there is a susceptibility condition, I won't call it a gene condition, then people should know about that. Is there a protective one? I know people that drink moderately, which is more than modest, that seem to be doing okay. And there's some people who have severe alcohol use disorder and are still cognitively with it. And how in the world that is, I don't know. But I think I think what we need to do as scientists and as a society is manage alcohol use, manage and make it so that it does not lead to disease or disorders, but can still be part of our social life.
Mhm. That seems very practical.
That's my pitch.
Yeah.
That's my pitch.
Um, this is a bit of a different direction now. So you've mentored
A few people, yeah.
yeah, I would say a fair number of people who have gone on successfully. What thoughts do you have? A philosophy of mentorship? What idea do you have about how mentorship should work?
That's interesting. Yeah. We don't have a large group of postdocs coming through. That's not the SRI is a not-for-profit standalone research institute. So we don't get postdocs like you do in the university as much, and we're certainly not student run. So the people who've come and worked with us have almost and collaborate. We see them almost as collaborators. So we work very closely personally. But I see mentoring. I talked to a young lady on Saturday. They asked me the mentoring, and I tell them about research. Research is a hard way to go. I once talked to an opera singer. He said there are only two reasons to do it. Either you can't live without it, that is, you just have to do it. You can't live it, or you can't do anything else. And so, I advise people to think about alternate life. Not only work life, but also what happens if a research career doesn't pan out. You have something else that you can do or you love. I think you should choose something that you really care about. You got to care about it. You got to have some passion. I mean, you say we're somewhat technology driven, but our passion is what can we see in the brain and behavior that is the result of alcohol use disorder. And then I also tell them that you need to become very proficient in something, some technical thing. You know, you need to know MR physics if you're going to do fMRI, you know, you should know something about MR physics. You should know how an MR scanner works. You should know what a T1 means. You should know how the bold signal comes about. And you should be able to take the data from the scanner and do something with it yourself. You know, I mean, if you're in biochemistry, studying the biochemistry of alcoholism, you know how to do that. I see a lot of people that are kind of coming into the field that don't have a rigorous underlying basic capability or a basic what's the word I'm learning? Yeah, basic facility. You know, I'm a biochemist. I'm a neuroimager. You know, I'm an image physicist. I think people will look like you know, you're a model that you're a basic, probably biochemist to start with, and certainly an MR physicist in spectroscopy. And you know, I tell people that if you really want to succeed, don't be a user of that. Learn to do it yourself. Have a basic science specialty that you can say I have a basic science knowledge about something. I advise people to do that. I don't know if any of them take my advice.
It looks like they do.
Yeah.
I'll insert something. A while ago in this conversation, I said about you talked about you picking up technologies, and my sense was not that you're technology driven. It's that you have your questions, and these technologies become available, or you see them becoming available, and you grab them, and use them to answer your questions.
Yeah, no, we do. Yeah, you know, you're absolutely right. And we've tried to stay on the forefront of that. And things come. I don't know. The field may be plateauing a little bit now, but there'll always be something new. There's always something in MR physics that's new. There's certainly always something for me to learn. That's for sure. That's for sure. Yeah. But that's my advice to young people coming in is have a basic science capability that you can step back on, that you could also use to study some other condition or concern. You know, it doesn't have to be alcohol use disorder. You want to, and you know, I guess broaden your field. Look, we got into it. I got into it from schizophrenia and alcohol as a comparator. Think about alcohol and other things. Of course, there are other substance disorders that people immediately think of, but there are other things. You know, I've been out of the schizophrenia field so long, I don't know, but it used to be the schizophrenics drank a lot. It wasn't good for them. And interesting thing now that our recent interest in the thalamus, because Manoj Saranathan, who's a now professor of radiology at UMass, when he was with us, he developed this subsegmentation of the thalamus that we've been applying. It used to be you could measure the whole thalamus and quantify it. Now we can get it down to about 10 nuclei. We group them into about 4 regions because to get SNR. But pain and even George Koob in a recent review article said use of alcohol to relieve pain may be an entry into the addiction cycle. And at one of the meetings 2 days ago, somebody said there's no good results of taking alcohol, using alcohol. And my cardiologist says there's nothing good comes from it except it makes you feel good. But Killian turned to me and said, that person's never had back pain. He says, alcohol relieves my back pain. And so I'm very interested in that. That's a new thing. So yeah, there's where a technology advance has led us to be able to look at, where in the thalamic relays where we might see the modulation of pain by alcohol.
Uh-huh.
So yeah,
Uh-huh.
that's interesting. Yeah.
For the research field
Yeah.
in general, is there anything you would like to ask of us?
The research field. That's interesting. I've never thought of it that way, Graeme. I guess
You could ask us to be doing
to be
something in some way.
the field to be doing something. I didn't give that one a lot of thought. I may not. What does the field need? You know what the field needs? Get rid of these Zoom meetings and have people meet. I mean, there is nothing like in-person meetings. I mean,
Yeah.
I get all jacked up here and jazzed up. You get to meet people and talk about things, and I talked to Fulton in the hallway about we've got some fMRI of real binge effects. I'd like his group to analyze them with their exact same protocol that they do with the adolescents, because I think we find very much differences, and they need to be analyzed exactly the same. I talked to you in Brazil about the glutamate enrichment.
Yeah.
You don't get that on a Zoom.
It's a common theme in these interviews that people have whole experimental directions or careers affected by someone they met at breakfast.
Yeah. Oh, absolutely. Absolutely. And the other place for that is in study section. I mean, I learned so much in study section. First, reading people's grants and how not to do it, but also all the people I met in study section. I mean, that was great. And counsel. I mean, that was also. And they've quit having these things in person, and I think that's a real shame. I think that's important.
But I would say that over the years, you and Edie Sullivan have mentored me, have given me guidance.
Well, I appreciate that.
And a lot of this is because we can be in person.
Yeah. Oh, yeah. Oh, yeah. Oh, I got another person, Chris Conkey.
Oh, yeah.
Yeah, another person that I met at a meeting, and then has collaborated with. And he came down and spent a few days with us recently, but we did, some of the very first imaging of his monkeys we did together. We got that atlas, we developed the monkey atlas, and I still do think, well, the glutamate work that you're working on is what Chris and I started with a couple of years ago. Yeah, another one of, I didn't mentor him, but it's funny. You say mentoring, I say collaborating. It's interesting because I see this as, I don't see the people that I've done as children that I'm teaching. I see it's such a two-way street.
Oh, even mentoring can be, even when you're teaching someone, it can be two-way.
Yeah.
You have given me guidance.
Yeah. Oh, yeah. Yeah.
And one last question. For members of the public who may watch this video,
Mm-hmm.
is there anything that you'd like to say directly to them?
Oh, sure. I mean, look, we've demonstrated that excessive alcohol use can be detrimental for your brain and your behavior. There's no question about that. The longer you do it, the worse it gets. The older you are, the worse it gets. But you can arrest the changes, and sometimes you can reverse them. You can get better. And so it's never too late to stop. And you don't have to stop completely. It's never too late to cut back. A lot of good things will come to you if you do cut back. You'll sleep better. You'll feel better. You'll be more mentally alert. You'll be a safer driver. So not only are you helping yourself, you'll be healthier. You'll lose weight, especially if you also quit smoking. And that's something I hadn't mentioned, but an awful lot of people with alcohol use disorders also smoke, and so it's a double hit. But you'll feel better, your family will feel better, and the public will be safer. And so there are a lot of reasons to drink in modestly and in moderation. You don't have to be a teetotaler. You don't have to cut back completely. Don't have to be abstinent, but you can modulate what you do, and you'll feel better, and everybody around you will feel better. So that would be my advice.
Thank you, Dr. Pfefferbaum.
Thank you, Dr. Mason.
Enjoyed talking.
How long have we been going? Oh my God.
Around, I'm not sure. My computer's on Eastern time. But how are you feeling? Would you want to do a few questions on TK, or do you want to stop and just?
Sure, go ahead. Ask me about TK. Yeah, because I saw Susan last week.
Oh,
And I
good.
saw Teddy, his grandson.
Yeah.
Yeah, sure. Ask me about TK.
All right.
Ask me anything.
All right. So this will be separate. We'll have to put
Okay.
it together separately.
Okay.
So how did you come to know TK Lee?
Okay. So I met TK Lee at a RSA at one of the private gatherings. I don't know why I was there. They were pouring wine, and I noticed that TK didn't drink. It's before I knew that he'd had stomach cancer, and actually, the worst thing he ever drank was a bottle of regular Coca-Cola because he got hyper and then hypoglycemic. It was really, really awful. Yeah. But I said something about, well, I can have this because my liver enzymes are induced. And he said, young man, it has nothing to do with your liver enzymes. So TK taught me that I better learn something about alcohol physiology. So then my next relationship with TK was through INYA, the Integrative Neuroscience Initiative in Alcohol Use. Subsequently, I have two publications with TK on our animal work with INYA, and then he became a personal friend. He stayed at my house when he came out to the RSA at San Francisco. He once, I think, tried to recruit me to Indiana. I wasn't sure. TK was kind of elliptical. That's how I would describe TK's. I once, oh my goodness, you may have to edit this out.
We can do whatever you do. We'll show you the video.
Okay. I did a site visit of TK's center in Indianapolis. On the site visit was a man named Don Jewett. Don Jewett had been one of my teachers in physiology in medical school. He subsequently went on to become an orthopedic surgeon, which will show you his level of social skills. So Don discovered the auditory evoked potentials. He had a paper in Science on it. Don is on this site visit because Sean O'Connor was doing ERP work. At the end of one of the sessions, we're going to dinner, and TK is driving. And Don Jewett's going on and on. We're sitting in the back saying, he says, I think I discovered the chink in their armor. I could see TK kind of twitch. It's a little like Barbara McCrady's yellow dress thing. So you may want to edit that one out. But talking about being elliptical, in the site visit, I don't know, somebody asked a question. Somehow TK interjected something. It gave a fact. And somebody said, what do you mean by that? Nothing. Nothing special. TK, he was a man of few words in those situations, but we became personal friends. I mean, I consider it a great honor to have two publications with him. Like I say, I went to China with him. That was a great time. And then when he became head of, oh, well, like I say, I couldn't tell whether or not he was trying to recruit me to Indiana at that time. He was asking funny questions, and I wasn't sure whether he was looking. Um, and when he went to NIH, NIAAA, I visited a couple of times. When I'd come to town, I'd often go to his house for dinner. Susan would have us over. There was one time that he had an affair, a dinner, for people. Was it because of the French people? I don't know, but they didn't provide. The NIAAA wouldn't pay for it, so I think he paid for it. So I got a case of wine from California. Let's see, you couldn't get it in Maryland. You had to get it in the district. Antonio, I had it shipped there. Antonio picked it up and smuggled it across the state line to TK's house, and so that we had the wine for that. And so I got to know Susan as well. And so then, of course, in the later years when TK got sick, we visited often through in Canada. Okay, so this is a long story, but I was the head of the imaging analysis section and set it up all the imaging for in Canada. And we had to have what we called traveling phantoms, where somebody would go around to every site every year. I'd go along too and make sure they were doing it right. And then we had a brain to follow and see if there were site changes. And so we would visit with TK and Susan. So Edie was the phantom. Susan used to call him the phantom. And then of course in the later years when TK was sick, we would visit frequently and got to see him, and that was very sad to see him deteriorate as he did. I remember the last time he kind of spoke in public. There was a festschrift for him. I think it was at UNC, not at Duke. Maybe I had this. It was either Duke or UNC. Fulton was there. TK was in a wheelchair, but he was still sharp as a tack and able to talk. And then it was here in Minneapolis that we had his memorial. The last time RSA was here, and we had his memorial. And I likened him to Erik Erikson's Stages of Man. The final one is the stage of generativity, where your role is to be generative and bring on the next generation. And TK was that way. He really was. And then, so we saw Susan 2 weeks ago when Edie and I went to Duke and had dinner with her. And then yesterday, TK's grandson, Teddy, who's working in VJ's lab, came up and introduced him to me. And so it's been multi-generational. So TK's spirit lives on. Still, he and Henry are the two influences in my life in the field.